Hello everyone, my name is Maria Rodriguez Ornelas with Cahuilla Delta, host of tonight's virtual wellness chat, where we talk all about hip and knee replacements with Dr. Seth Kreiner and Dr. June Kim. Thank you for joining us tonight. Dr. Kreiner joined us shortly after he completed an orthopedic trauma fellowship at University of New Mexico School of Medicine in 2016. He graduated of Western University of Health Sciences and has been practicing with us since. Dr. June Kim recently joined us after finishing a fellowship at Wake Forest in knee and hip replacements. He joins us, or he actually went to Western University of Health Sciences and has graduated there and since has been practicing with us. Today we're going to do about a 12 to 15 minute presentation with Dr. Kreiner and Dr. Kim regarding knee and hip replacement, and then we will open up for questions that you may have. For those of you joining us on GoToMeeting, you will be able to follow along in our presentation. And those of you guys joining on Facebook or Instagram, make sure to chime in on social media, and you can download the PowerPoint going to cahuilladelta.org/ortho and follow along. If at any point in the presentation you have a question, you can go in and ask in the GoToMeeting chat box, or you can email questions@kdhcd.org, and we'll do our best to answer them live. If afterward you have any questions, we have a number you can call, 624-3804, and we can set up a time for you to speak to someone to answer those questions if you have any lingering questions after the presentation. You can also chat with us during our Facebook and Instagram Live. We'll also post tonight's presentation on our website following the seminar, and you can always go back and watch it on Facebook and Instagram should you choose to do so. All right, we're going to bring Dr. Kreiner and Dr. Kim, and let's get the seminar started. All right, Dr. Kreiner, Dr. Kim, thank you so much for joining us today. How are you doing?
We're doing good. How are you guys?
Excited to be here. Thank you for joining us. Now, before we begin, let's talk a little bit about what Cahuilla Delta is doing to keep your patients safe during the pandemic.
So for all of our elective cases, everybody gets checked for COVID a couple days before surgery. We ask everybody to quarantine after they get tested for COVID to try and make sure that they don't get it over the weekend before their surgery. And then obviously all our nurses are wearing masks. All our staff in the hospital are wearing masks. We're very careful. So,
Dr. Kim, can you chime in to speak about kind of the precautions that we're taking, just like Dr. Kreiner is mentioning in the hospital?
Yeah, I think we're being very cautious with every patient. We're always putting patient first. We always want to do everything in a safe manner. So everyone gets tested prior to surgery. Everyone in the hospital is wearing masks. We're doing the appropriate precautions. We're all being vigilant. And so I think everyone's doing their part to keep everybody safe.
from a hospital standpoint, the patients who have elective surgery who stay overnight go to separate floors, so they don't get intermixed with any patients that have COVID that are in the hospital. The staff that works in those areas do not take care of COVID patients, so you're not going to have a nurse taking care of a COVID patient but then taking care of you, because that would obviously be concerning for COVID getting passed from that patient to the elective case. So everyone is kept separate.
And we want to ensure our patients, their safety is our first priority, first and foremost, and we are doing everything we can to ensure that our patients are safe. Now, before we can go into our presentation, Dr. Kreiner and Dr. Kim, why don't you tell patients that Cahuilla Delta is the best place to have their hip or knee replacement? Why come here?
Go ahead.
I think we have a great group of surgeons here that provide. We're all great surgeons. I think we do a great job in terms of knee replacements and hip replacements. But not only the technical aspect, we have great staff. It has to be a team-driven effort. We have, from the preoperative nurses, to the the OR staff, to even the post-op, the floor nurses. We have a great staff that knows what they're doing. We're all on the same page, and I think we have a great team effort at Cahuilla Delta, and I think that really helps patient feel like they're getting the best care that they can get.
Dr. Kreiner, any thoughts on the world-class care we deliver?
Nothing to add to that. It's well said. So.
Perfect. So we're going to go straight into the PowerPoint. So.
Yeah, so I was going to start with the total hip part of this, so that'll be the first part. So let's go up. So Coweta Delta Medical Center, it's been here for 60 years. And so if we go to the next slide, this is a picture of our orthopedic surgery team. The one person on there, Dr. Dave Sertica, actually left recently, but otherwise that's accurate. Everyone here does a great job. And then we have Megan Goddard's our nurse practitioner, who works with us and kind of helps quite a bit with throughput and helps troubleshoot anything that could be going on in the hospital with any of our patients. So next slide. So this is supposed to be a picture of Dr. Kim and myself. Oh, is it? Did you guys?
It's there.
Oh,
It's there.
it's not on the. Yeah. So this is myself and Dr. Kim. We've actually known each other since. So we actually went to the same medical school, same residency program. We've known each other. I was probably a third-year resident when he was a fourth-year medical student rotating through our facility, and then I was his chief resident. And then he rotated down here with us when I was practicing down here, and we liked him so much that we offered him a job. Anyways, we've known each other for a long time, and we all kind of have the same goals when it comes to patient care.
Now, I'm going to stop you right there. When it comes to patient care, you talk about goals. What does that mean? What does that mean for our patients?
Well, patients come in and they are complaining of hip pain or knee pain, and you try and identify what is the cause of the hip pain or knee pain, and there's multiple causes. It's not always because somebody has arthritis, and then you're just trying to do the right thing for the patient and fix the problem. And so in this case, with what we're talking about today, a lot of people have arthritis, and so we replace joints that are arthritic, and people do very well. It's we'll get more into that here in a minute. So many arthritis sufferers say that pain is a problem. Obviously, that's why they're coming into our office. If they didn't have pain, most of them probably wouldn't walk in our door. But the biggest thing, and I hear this over and over from patients, is they lose their mobility. And they start needing to use a cane or a walker, or sometimes their leg gives out on them and they're at risk of falling, or they actually fall. And this can cause them to lose independence, because if you got to take a walker everywhere you go, or if you're always needing your cane, you're going to go shorter distances. You're not going to be as active. And so for obvious reasons, arthritis is a problem. So let's go to the next. So on the left side of the screen is a normal hip, and what you see the arrow pointing to what is a normal joint space, and on the right part is a joint space narrowing, and you can see there's really no space between the hip joint, which is a ball and socket joint. So I often use, when I'm talking to patients, you got the hip socket to the left hand, ball goes into it, and there's supposed to be space on the x-ray, and if there isn't space, that means that the cartilage isn't there anymore, and that's what an arthritic hip is. And people complain of grinding. They complain of pretty significant groin pain when the hip looks this bad. So next slide. So treatment options. Obviously, first things, we always are trying to avoid surgery. Surgery isn't something that should be taken lightly. We get great outcomes, but still you should focus on the non-surgical stuff first. So a lot of people, one of the number one risk factors for developing arthritis is being overweight, and so losing weight can actually help quite a bit with the pain that somebody's experiencing. And that includes eating healthy, that includes exercise. Sometimes there are medications that we can be given. We can do injections into joints, and that can help calm things down. And then physical therapy, it we'll talk about this maybe a little bit more later with knees, but with hips, doesn't tend to work as well, but it is worth trying, certainly in the more mild setting of arthritis. When someone has severe bone-on-bone arthritis, physical therapy usually doesn't work. And then other surgical options, arthroscopy, that's more for the non-arthritic hip situation. And then obviously joint replacement. So cortisone injections, when you hear cortisone, it's just the generic name for what we're doing. There's a few different types of medications that we use. And most of these can be done in the office, and we can do them in any joint, and it can help calm down inflammation. And it works about 90% of the time, but one of the issues is it can only be temporary at times. And so, sometimes I've had people who it works for a year, and then you have other people where the injection works for a week and then it immediately wears off. And so, but you really don't know until you try. And so I usually encourage people to at least try once to see if they can avoid surgery.
Now, before we go on to the next slide, I want to remind the people that are just joining us on social media, if they want to see the PowerPoint, they can go to koreadelta.org/ortho, and on GoToMeeting, you can log in and the PowerPoint will be there for you. So let's move on.
So other options for injections, there are lubricants. We don't really use those in hips. We use it more in knee replacements. There's platelet-rich plasma. This is a newer technology. Some people are injecting this into joints. It's not going to fix anything long term, but the goal with any of this is always pain relief. And so there are some people who talk about getting some pain relief from doing a platelet-rich plasma injection. And so sometimes it can be worth trying. It's not covered by people's health insurance, however, so it's an out-of-pocket cost to the patient. Stem cells, something that a lot of people have been hearing about, and I get this question frequently. Oh, well, is this going to regrow cartilage for me? Maybe if I just do this, it will stop me from getting arthritis, and it does not help. And so stem cells in a very mild arthritic situation, if you have a few $1,000s lying around to spare, can work. They're very expensive, and it can calm things down, but ultimately it's not going to replace cartilage. So scroll down a little bit. Down. There we go. When other treatments no longer bring relief, it may be time to consider joint replacement surgery, and that's one of the things we're here to talk about, and this is what we do quite a bit of. And so let's go to the next slide. So what qualifies you? You may qualify for joint replacement if you have arthritis on x-ray, failed non-operative treatments that we've briefly gone over. When people have disabling pain, I would say that pain is relative. Everyone experiences pain differently. So if you have no arthritis on your x-ray but have disabling pain, I think most of us would be very concerned about replacing somebody's joint because we wouldn't be convinced that we were going to fix the problem. But if you have significant arthritis and you have disabling pain, it's usually a home run for us to go replace somebody's joint. And then you have to have acceptable surgical risk. So part of any clearance for surgery or getting set up for surgery is we talk to your primary care doctor. If you have a cardiologist, we're going to talk to your cardiologist. We may need you to see them to make sure that surgery can be safely done because you need to come out the other end of surgery. So that's what we mean by acceptable surgical risk. So normal hip, this is kind of a nice little diagram. And the socket is, so again, ball and socket. So socket's here, ball goes in here. The femoral head or the ball part of the joint is purple in the picture. And that purple is what provides the space on the x-ray that we showed earlier. and the ball is supposed to be nice and round. Okay, so let's go to the next one. Whereas in this picture here, you can see the cartilage is more of a white color in this picture, but the cartilage is irregular. It's got cracks. There are areas of cartilage missing. There are little bone spurs on next to where the ball is, and those bone spurs, when moving your hip around, can pinch things and cause a lot of pain. So what is hip replacement surgery? So it's made up mainly of 4 components. So on the socket side, you have to put a metal shell that bone will grow into. Sometimes it takes about 6 weeks for bone to grow into it typically. Sometimes we'll put a screw through it to just kind of hold it in its place if we feel like we just need a little extra help with it so it doesn't move after surgery. And so that's something we figure out during surgery if we need to do that or not. And then there's a plastic liner that kind of serves as a replacement for cartilage. And then we have a metal ball. It can also be made of a material called ceramic. And then the ball needs to get attached to something, so there's a stem that goes into the bone that the ball attaches to. So, okay, so I think we're going to pass this over to Dr. Kim now.
All right. So, in 2010, there's a lot of knee surgeries being done. Over 600,000 knee replacements, and we're expecting by 2030 it's going to grow exponentially. And they're expecting 3.5 million knee replacements annually, which is quite a bit. And we know that nearly half of Americans will be diagnosed with osteoarthritis at least in one knee in their lifetime. And so you can get knee arthritis for a variety of reasons. It could be due to osteoarthritis. It could be due to post-traumatic, after a significant injury when you were younger, or if you're in an accident. You can also just have rheumatoid arthritis or, just inflammatory arthritis. Go to the next slide. So, when we look at the normal knee here, this is a great cartoon here. There's essentially 3 compartments in your knee. We have patellofemoral, which is kind of beyond the kneecap. We have the inside part of your knee, which is the medial compartment, and then the lateral compartment, which is the outside part of your knee. Essentially, the main bones in your knee is your femur, which is your thigh bone. You have your shin bone, which is the tibia, and your kneecap, which is the patella. You also have a small bone there as a fibula. This is just a good cartoon. But again, you have basically 3 compartments. So I think, patients ask all the time, when should I get a knee replacement? And a lot of times I tell them, I can't make that decision for them. I can provide them the options, whether it be conservative or non-surgical options, and then the surgical options. Patients typically know when they're ready. They have pain every day. They can't walk. Even when they're going to the grocery store, they got to think about their knee before going to the grocery store. So when they have limitations in activities of daily living, again, pain on a daily basis, even pain at night that wakes them up at night, and the quality of life is just going down, I think that's a great time to actually consider a knee replacement. The other thing is, they've tried the non-operative things. They've tried the cortisone injections. They've tried medications like Tylenol, Aleve. They've tried the gel injections. They've tried everything under the sun, ice, heat. But still, they're still having pain every day. Then I think it's a great time to, at least consider it. And obviously on X-ray, when we see X-rays, it has to match up, with their symptoms as well as the imaging studies. And so, if they have bone-on-bone arthritis, and they have all these other symptoms, then I think it's a good time to think about it. There's lots of different implants that are available today. I think one of the other questions that I often get is, how long is my knee replacement going to last? I'm, maybe 50 years old, and I don't know if it's going to last me my lifetime. But I think the old implants that we used to have, I think it was the plastic that was wearing out over time, and I think it was around 15 years or so when the plastic began to wear out. But nowadays we have newer designs, we have better materials, especially the plastic, and we're hoping at least that's going to last at least 30 years. And on the bottom picture, we have this crazy looking implant there. That's usually for some complex primary, we have big deformities or in a revision setting. So this is just an example of just what a knee replacement looks like from a pre-op X-ray to a post-op X-ray. And when you look at the pre-op X-ray here, you see that the inside part of the knee there, there's the joint space is quite narrowed down. You start to have bone spurs. If you look at the density of the bone, it's much more white, and that basically what we call sclerosis. And what ends up happening is that the knee begins to experience much more stress in that area, and it becomes marble-like. A common kind of metaphor that I use in clinic is, treads on a tire. I like cars, and so I always mention treads on a tire. The treads are wearing out, and the treads aren't going to come back. The more you drive your car with worn-out tires, the more worn out it's going to get. And eventually, it's going to just be a rim. And so on the right side, it's when we replace the knee, now you see that there's actually space between the femur and the shin bone or the tibia. And the alignment's also restored. Thanks for your attention.
Alrighty, well now we'll open up for a few questions. The first one came in on social media. One of our watchers asks, stem cells will help for how long?
I don't use stem cells in my practice. I think the research right now, the data isn't convincing to actually support the use of stem cells. We actually have a committee or a society that actually makes recommendations for or against certain treatments based on the available evidence. And I think today they don't support or they don't have strong evidence for the use of stem cells for knee arthritis. But I think if you're interested in trying everything, without surgery, I think you can try it. But, usually the rule of thumb is if it's not covered by your insurance, it's probably not evidence-based. It's not backed by research. And so I can't really say how effective stem cell would be or stem cell therapy would be for knee arthritis or hip arthritis.
Anecdotally, I've talked to people because the research is not great out there. And you have people where it doesn't work in at all, and you have people where it gives them 6 months of relief. I just think the biggest thing about stem cells, if you're going to go spend $3,000 to $5,000 on an injection that might give you 6 months of relief, and it's not going to repair any cartilage, I think that's a whole lot of money to spend on something that's not going to fix your problem. So.
Now another question that came in. Is there any age limit for joint replacements?
So
Yes,
I use my example. In the last year, and this doesn't happen a lot, but in the last year I have a 93-year-old and a 97-year-old who I've replaced joint knees on. They failed every conservative thing on it. We didn't do stem cells on them because they were both severely bone on bone, but they failed everything else. And both of them were starting to have to use a walker. Both of them, their only medical issue was high blood pressure. They were sharp as a tack. And I think one of them's mom lived to 105 or 107, and the other one, similar thing. So I don't think it's, I don't think 97 is an absolute no for surgery. But you have to be, she was healthier than a lot of my younger patients. So, and again, she failed all conservative management, and she had to go see her cardiologist, and we talked to her primary care, and we made sure that we were good to go. So.
Yeah, I think that's why we always talk about risks and benefits. We don't consider age as the a cutoff or a limiting factor. As long as they're healthy enough to undergo surgery, I think it's a great idea. Especially if they have family that was living up to 105, and if they're 97, if you have 8 good years of relief with pain relief, I think it's slam dunk.
Perfect. Now, what is the first step someone with knee pain should take?
Medications wise?
What's the first step?
Yeah, what's the first step?
I think you have to first figure out why you're having knee pain. You can have knee pain for a variety of reasons. Obviously, if you're a teenager, we're not going to be thinking about arthritis. So I think seeing your primary care physician or orthopedic surgeon, at least get a workup. Get a clinical examination, whether it be X-rays, and they might start ordering MRI. Then at least you can pinpoint what the problem is. It's hard to say what the first step is in terms of treatment without exactly knowing what's going on. So I think the first step is getting a diagnosis.
So to get that diagnosis, obviously we have to establish care. So Can they establish care with you for an initial assessment, and is a referral necessary?
That is highly dependent on people's health insurance. So I would invite anybody to, if they're having knee pain, you can certainly call our office, and they'll ask for your insurance information, and our staff will be able to tell you, oh, we need a referral for you, or no, we don't. So if we don't need a referral, we're going to be happy to see you, obviously. If you need a referral, we can help facilitate that process for patients. So.
Now, the best medicine is always preventative, right? What can we do? So how can we avoid to have a knee replacement or a knee replacement surgery?
Yeah.
All right, a couple tips. I think we mentioned one of the slides. I think maintaining a healthy weight will help. Studies show if you take off even 3 to 5 pounds, or even 1 pound of your weight, that can translate to 3 to 5 pounds off your joint. So, if you lose 5 pounds, that's 15 pounds off your knee. So, that can be very beneficial.
Yeah, weight is probably the number one risk factor and predictor of somebody developing arthritis, and so figuring out how to help them get their weight under control is something I certainly talk to my patients about. I'm sure Dr. Kim does. I know our other partners do also, and so weight is the biggest thing. I usually tell people to just live life, though, because honestly, if you're starting to get arthritis and that train's on the tracks and it's going to keep going down the tracks, and short of a bad accident, it's going to happen whether you sit on a couch and don't do a lot, or whether you keep riding your bike or jogging or running or doing stuff.
So let's say somebody now needs surgery. One of the biggest things that comes to mind is, where will be the surgery? How is it going to happen? So where will surgical incisions be for hip replacements?
So hip replacements, there's a few different ways to get down to the hip joint. Most of the doctors here at Cahuilla Delta come from what's called an anterior incision. So it's on the front of your thigh. It's usually about 10 to 15 centimeters long, depending on the patient. And so that's what the majority of us here at Cahuilla Delta do. One of Dr. Frank Fang, he uses the anterolateral approach, which is an incision more on the side of the hip. And that's been shown to be very effective as well. The recovery from an anterior incision tends to be a little quicker on the front end of surgery, but if you look at the research at a year out, it doesn't really make a difference. So the biggest recommendation I tell patients when it comes to that particular portion for the incision is that your surgeon needs to do what they are most comfortable with and what they are good at doing, because you just taking surgeons out of the comfort zone on stuff like that's just not a good idea. So
now you're in the surgery room, you're getting surgery. What's happening, and how long does it take for a knee replacement?
I think surgical times vary depending on the complexity of the case. It can range, typically, I would say on average an hour, hour and a half, depending on the case. But again, we all take our time to do the right thing, and we try to do quality work. So whatever is necessary.
Now, what is an artificial knee, and how does it stay in place?
Okay. Yeah, so there's a couple of ways to do a knee replacement. The tried and true method, which is the gold standard, is a cemented total knee replacement. Essentially, what we do is we make the bone cuts so that the implants can fit right onto that bone, but in between we apply cement. Okay, it's called bone cement. That's just one way of doing it. That's just the gold standard. But nowadays, I know there's talks of doing a cementless, so without cement. So these are what we call cementless total knee replacements, where the backside of the metal implants are highly porous. Back in the early days, they did use cementless total knee replacements, but they had a high failure rate. And I think that was due to the poor design at that time. But I think now we're getting a better understanding of how things work, and we're engineering things in a better way, especially with 3D printing, highly porous metals, And so a cementless total knee replacement is another way to do it. But the gold standard, tried and true, is the cemented total knee replacement.
Yeah. And if we're using a cementless knee replacement, the person has to have good bone quality. So somebody who's a little osteoporotic, cementless knee is usually not what we're going to do. That is going to get cemented in.
So we just had a chat come in on social media. One of our viewers asks, can one leg be longer after the knee replacement?
Knee replacement surgery does not cause one leg to be longer than the other. It can happen in hip replacement surgery, but knee replacement, the instrumentation that we use to make the bone cuts is very precise. It's within a millimeter. So there are people who complain afterwards that they feel like one leg's longer than the other. I think that's typically in patients who had a lot of deformity before the case. So we all kind of joke, a lot of us joke about the cowboys who walk with their legs bowed out because they got terrible arthritis. When you go fix that and you do a knee replacement, you actually straighten their leg out, and that will functionally make it longer, but it makes it feel longer because it's longer than what they're used to.
Yeah.
But if you then go replace the other side, they'll have a match set. Yeah.
So previously after this question, Dr. Kim was mentioning some of the earlier practices, right, and the complications that would arise. So in this day and age, with the advances that we have, what are the possible complications of a hip replacement?
I think number one complication is infection. I think with any sort of joint replacement, that's the number one thing that as surgeons, we're all afraid of, and we always are kind of cautious of is infection. I always tell patients, anytime we make incision or skin incision, we all have bacteria that live on our skin. Despite of how much prep we do, give antibiotics, there's a risk of infection. And not only that, if you get a hip replacement or a knee replacement, I don't want to scare patients, but you can later down the line get an infection, let's say, a urinary tract infection or a bad GI infection, and that goes into your bloodstream, and you get sepsis. And then, from that sepsis, it goes to your metal implant, and so you get an infection, along that prosthesis, whether it be the hip or knee. And so I think infection is probably the most feared complication. And then number two, obviously, with the hip replacement is dislocation or instability.
And then one of the things one of the questions people commonly ask us is, well, what's your infection rate? At Cahuilla Delta, this is actually something that we track very closely. The orthopedic surgeons are meeting monthly, and we're talking about the data from this. And I know our data from 2019 was we had a 0.25% infection rate for all joint replacements. I think we had one infection. 2020 hasn't totally finalized yet. It's about to finalize, so we'll have data on 2020, but 2020 was pretty similar to 2019 when it comes to infections, and so it's something that we take pride in, and because it's just such a bad problem to have when it happens. Yeah. So that means 1 out of 400, joint replacements that come through our facility get an infection.
So we're happy to know that we have caring surgeons like yourself who put the priority of the patient. The patient is always priority, and their care is priority. So we have another question coming in our chat lines. How frequent do insurance companies deny hip surgeries and demand physical therapy before reconsideration?
You want to answer that?
It doesn't happen very often. Usually, if they're going to try and deny something, I get a phone call from a representative from the insurance company and find out what the issue is. The other thing is, usually before I even ask to do a hip replacement or a knee replacement, I've already gone through and checked all the boxes. So I've done some version of conservative management, injection, some of the physical therapy, and so it doesn't happen a lot.
Yeah.
And sometimes it just doesn't happen.
Yeah.
So the next question just came in. Someone asks, when should I consider cortisone for hip and knee replacements? So when should we consider the cortisone?
Prior to a joint replacement, is that the question?
Yes.
Yeah, so I think if you're still kind of on the fence about getting a knee replacement or a hip replacement, you're just not sure yet. Let's say you have bone-on-bone arthritis, but you're a little afraid to, commit. You're still having pain every day, but you want to try, the conservative things first. And I think that's a good option, to try cortisone injection. I think there's one caveat, with knees, you can get injections, every 3 to 4 months. Whereas in hips, I don't recommend getting, routine cortisone injections for the hip because it can certainly accelerate the wear in the cartilage.
No, I would agree. This is a conversation I think both of us probably have every day in clinic with patients. Yeah. And when I have someone who's on the fence about getting a joint replacement, I want them to feel like it's the only option they have. And so if they haven't tried a cortisone injection yet, then I'm usually going to push them to do that because they need to feel like they didn't have any other option. We don't get a lot of complications, but if you're the one, it's 100%, Mm-hmm. So for me, it's, 1 out of 400. For you, it's 100%. So you need to really be convinced that you need your joint replaced. So, and our job is to educate. Dr. Kim kind of hinted at this earlier, and maybe this is said a different way, but, our job is, I feel like my job is to educate patients on what their options are and try and help them decide what the best thing is for them. But I'm not going to tell you, no, you just need to replace your knee, so.
Now, one of our viewers just chatted in and says, I feel like my knee pops out of place and is very painful and then goes back in and then pain stops right away. What causes that?
It can be a couple things, I don't know when the knee pops, if it's just kneecap popping out, to the side. It could also just be, when you have worn out your knee so much and a lot of these patients, when they have severe arthritis, they've, degraded away or torn away their ACL, they have no meniscus, which, are structures that provide some stability to the knee. And so when you have severe arthritis, there can be a tendency for the knee to feel unstable, you may not trust your knee as much. But again, it's hard to say just by popping in and out, if it's due to arthritis or if it's just a knee just popping out or kneecap.
There's 2 other things, or that I would add. Loose body. Mm-hmm. Sometimes people who get a little arthritic can get something loose floating around their knee, and it pops and then moves out of the way, and then it doesn't hurt anymore. And the other thing, it would be a meniscus tear. So.
All right, so we're going to go on to our last question. What can I expect during recovery and rehabilitation after surgery for hip and knee?
You want to do knee and I'll do hip?
Oh, sure.
Yeah.
All right. I tell them, knee replacement is a very painful surgery. The knee patient, they struggle a little bit more than the hip patient. I always say, the first 2 weeks are very painful. I always draw them a little sad face, in clinic as a cartoon to show them how they're going to be feeling the first 2 weeks. They're going to be using a walker for a week or two and then for a cane for a week or two. But usually by 6 weeks, they're feeling okay. It's not a sad face anymore. Maybe it's just a straight, lined mouth. But it's usually about 3 to 4 months is when they're feeling like, they've noticed a big difference. But, I'm not going to, make it look like it's not going to be painful. It is a painful surgery. And the reason is the knee is a very superficial structure. It's right there. You can feel your bones right underneath your skin. And that's why it's very painful.
Now, before we let you guys go, some chat lines are coming in.
Yep. I was going to say on hip replacement, typically not as painful as surgery on average. And recovery time, we are sending people home the same day after hip replacements, probably 25% of them. The other 75% typically stay one night. It's unusual for someone to stay 2 nights in the hospital after a hip replacement. And I would say the same thing goes for a knee replacement. And then I would say at about 6 weeks, people are feeling pretty good. When I see people at 6 weeks, just this week I had a couple people that are 6 weeks out and they walked in without canes into my office, whereas they were using a cane before surgery. So, and that's not everybody, but that's a reasonable timeline. I would say between 6 and 12 weeks is when someone would get rid of the cane from a hip replacement. Knee replacement probably takes till about 12 weeks for a lot of people. Not everybody, but a lot.
Now, before we let you guys go, some chat lines have been coming in. We're getting a lot of questions and thanks from people, a lot of your patients and people who are getting to know you just by this virtual wellness chat, who are very happy to have you here. So thank you to everyone who's chiming in. And Rose Ballesteros says, "Hi, Dr. Kreiner," and she misses you. We also have another patient, I think it's Jennifer on the line on social media. She says, "You guys are wonderful, great educators, and it's a great team to work with." And we remind all of our viewers that if you have any questions, follow-up questions from this chat line or anything that you guys want to discuss about joint replacements, please give us a call. The number is 559-624-3804. Now, you guys want to close it out?
I just want to thank you for just joining us today and spending time with us. Hopefully you found this seminar to be helpful. And if you have, again, any questions, please feel to reach out to us.
Yeah. So it's again, thank you for joining us. And Cahuilla Delta has been is a great partner with us, and they work very closely with the orthopedic surgeons here. Again, we meet quite frequently with the hospital, and anytime we're having something that we just don't like the way it's going or it's not perfect, the Cahuilla Delta's administrators are very responsive to us because we want everyone to have the best experience possible. Broderick Pavilion, where most of our patients go after joint replacements, is a wonderful place to stay. The nurses are excellent. They really know how to take care of them. So again, if you guys got questions, they can get filtered out to us. Phone number for the hospital is 624-3804.
All right, well, thank you everyone for joining us. We're going to wrap this up, and be sure to ask your questions, any follow-up questions with the phone number that Dr. Kreiner provided. Have a great evening.